Hello, everyone, and thank you for joining us for this concurrent session room on mobilizing and strengthening cross-sectoral investment partnerships and innovations for improved maternal, child, and adolescent health outcomes. Concurrent sessions bring together diverse professionals, experiences, and perspectives, examine new research, evidence, strategies, and practices, as well as engage with peers on emerging issues. We encourage you all to actively participate, ask questions, and share ideas with our presenter. Please use the chat box to type in your questions and comments during the presentation. If time allows, a couple people may be able to use their microphones to participate after each session. In the meantime, you can send questions through the chat. We will first be hearing from Nelly Wakaba from Financing Alliance Health, who will be kicking off this room session, followed by Cicely Thomas, who will introduce us to our second set of speakers. Now, without further ado, I will hand it over to Nelly Wakaba, who will be presenting Investing in Community Health for Improved Child Health Outcomes during COVID-19 and in the future.
Thank you very much. Good evening, good afternoon, good morning from wherever you are tuning in from. Thank you for joining this session. Now, with this pandemic, the COVID-19 pandemic, which has caused over 2 million deaths, sadly, these are our mothers, our fathers, our leaders, our doctors, our nurses, our community health workers. No one has actually been spared. And most interestingly is, and sadly to note, is that our children, though they may not be the face of this pandemic, are actually facing the brunt of this pandemic in very profound ways. 700 million children are actually going to be living in monetary poor households due to the effect of the pandemic. What does that then mean? It means their school may be affected. It means accessing healthcare will be a problem. It means accessing basic needs will also be a problem. And so they cannot be ignored, and we cannot ignore looking at this prominent issue. And so how then do we ensure that our children, our future, are not left behind? And so today, one of the avenues we are thinking about and looking at for our session today is how can we strengthen our community health programs, our community health systems, so that we ensure improved health outcomes, not only for our children, but also for our communities at large. So today I am very happy to be joined by my speakers who will actually tell us this story. How is community health worker program very valuable to them? What impact has it done? And we will be looking at 4 Ps. The 4 Ps for investing in community health worker programs. So listen to this amazing story. And to kick us off, we will watch a video from a real soldier on the ground. That's a community health worker program from Uganda called Prosby Mugengo. Over to you for the video.
My name is Mingo Prose. I'm a community my clients find me at home. I have to keep a distance when serving them. I use PPE, masks, gloves, and sanitizer when distributing posters to sensitize the community about COVID-19. One of the main challenges I have faced is that some clients are not able to come to me when in need of health services, and yet I can't go to them since I have limited PPE. I call upon those in leadership positions to provide sufficient and appropriate PPE for all frontline health workers, including community health workers, so that we can continue to support the fight against COVID-19 without putting ourselves and the people we serve at risk.
Thank you very much. That's our story from a soldier who is facing who is at the front lines fighting the pandemic, educating the communities, saving our children, providing essential health services. And so our next speaker is none other than Dr. Yeshitila Hailu. He is the head of programs at Amref Health Africa at the Ethiopia office, and he will tackle the second P. So we've seen the first P, which is protect our health workers. And so the second P for today by Dr. Yeshitila is programming that prioritizes community health workers. Over to you, Dr.
Good morning, good afternoon, and good evening, attendees, organizers, and speakers. Quite a privilege and so excited to make a few remarks on community health programming adaptations to reach vulnerable communities in Ethiopia during COVID-19 programming. Thank you so much, Nelly, for the introduction as well. I hope I can manage my talk in the given time. It's good to say a few words about the organizations that I have come from in line with today's topic before I go directly through my talk on the specific topic. Amref Health Africa is a leading advocacy force in the health system reform in Africa, and one of its advocacies is focusing on community health worker. And we have already embarked on a 5-year global campaign for community health workers, which we launched in March 2017 through its health system advocacy partnership program, financially supported by the Ministry of Foreign Affairs of Netherlands. It's mainly focusing on recognition, remuneration, standardization, and integration of community health workers and the program in the health system. So through that campaign and subsequent development of various advocacy guidelines and toolkits, the advocacy campaign has actually helped Amref Africanize later the WHO guideline, as you know, on health policy and system support to optimize community-based health workers program that was launched in October 2018 by taking the Amref Health Africa lessons learned into account. Amref Health Africa has access to the network of community health workers needed to stop the COVID-19. We are able to reach more than 1.2 million community health workers in the countries where we have presence. And we have curriculum for community health worker training and the technology platform as well for training community health workers. So in addition to that, we do have the community-based health management information system so that the community health workers can collect data on COVID-19. And we are privileged to be a technical partner of WHO in providing emergency and risk communication and community engagement. Just coming back to my specific topic today, on top of the communicable and the non-communicable diseases, pressure and burden on the already existing health system, this pandemic as a triple burden disease, along with the communicable and non-communicable diseases, like in any other countries, has brought with lots of challenges in the health sector and beyond, as we all know very well. Access to essential health service has been compromised. Reports and evidence of increasing trend of sexual and gender-based violence and other harmful traditional practices, including child early and forced marriage, as well as female genital mutilation, critical shortage of the healthcare workers, interruption of essential health service, particularly the essential health commodities. And according to the DHS2, the essential service utilization dropped between January and April 2020 in Ethiopia, where there is a significant decrease in contraceptive acceptance rate from 67 to 57, antenatal care from 70% to 54%, skilled birth attendant from 62% to 56%, postnatal care from 83 to 73%, and the percentage of pregnant, laboring, and lactating women who were tested for HIV as part of the PMHC testing dropped from 85% to 62%, and many others reasons that we can list down. just to give you highlights about the COVID situation in Ethiopia, as we speak, we have a total case of 135,000 plus, and it has claimed the lives of 2,083 people with a close of 2 million lab tests so far. The pandemic has actually diverted the health system attention and also the essential service provision. So there was a need to address these realities in a very innovative and contextualized manner through sound and resilient community health programming. So here comes the role of community health workers in both curbing the pandemic as well as maintaining and continuing the essential health service, particularly to the most vulnerable people, mothers, children, and young people. In Ethiopia, health extension workers, as we call it, community health workers, have played a critical role in all aspects of the pandemic response, ranging from prevention to detection and then response. So the question now is that, what have they done so far? And what have we supported them so that the health extension program in general and the community health workers in particular have become successful in reaching out to vulnerable communities during the pandemic. Bear in mind, when talking about community health workers program in Ethiopia, we are talking about the health extension program, which is a government initiative launched in 2003. And more than 40,000 government salaried health extension workers are deployed in the country. 2 health extension workers or community health workers are assigned to one health post where they are expected to serve 3,000 to 5,000 population. And the health post is the lowest unit in the primary healthcare unit. And they are providing 18 intervention package. So what we have done during the COVID pandemic, we have then mobilized the existing community health workers in partnership with the Ministry of Health in order for them to respond to COVID-19, mainly around 3 key areas, so that they are able to engage in risk communication and community engagement and community-based surveillance through prevention, detection, and response, through awareness creation to community on the pandemic and preventive measures, coordinating and leading the efforts of the community volunteers, such as women groups, religious leaders, youth groups, and so on, and through detection by conducting house-to-house active case finding and referral, and by supporting the contact tracing done by the rapid response team, and through response by compacting misinformation in COVID-19 areas, and by supporting the contact tracing done by the rapid response team. In line with this, AMREF has embarked on training of health extension workers on COVID-19 information and surveillance through digital learning solutions. So in collaboration with Ministry of Health, we have launched mobile-based training for health extension workers using digital technology, which has enabled all the community health workers to learn at their own pace and with their own mobile devices, basic or smartphone, from where they have been working. And today, we have trained a total of 20,000 plus community health workers, and more than 1,600 community health worker supervisors have also been trained. And we are planning to reach all the 40,000 community health workers. And at the same time, in line with the Ministry of Health implementation guide to maintain and continue essential health service, AMREF Health Africa has designed a virtual mobile-based training for health extension workers with the goal of developing their capacity and sensitize them to create demand, awareness raising about the continuity of essential health service and the importance of seeking the service during COVID-19, and also to provide basic essential service, particularly reproductive, maternal, newborn child health services to the community, particularly essential community level life-saving health services, and also refer clients for higher level healthcare service if required, and provide health education about the availability of service at each level. In my conclusion remark, we have witnessed that the community health workers are the backbone of the Ethiopian health system and beyond in any given country in the world. Community health workers should be well recognized, brought forward, and capacitated, even supported by digital technologies so as to ensure a strong and resilient public health system that could reasonably prevent, detect, and respond to any health threats or public health emergencies, such as the current pandemic. We have also witnessed that their active and effective involvement has significantly contributed to curbing the COVID-19 pandemic. Building their capacity and updating health extension workers with updated information on COVID-19 is also critical for the response. Ensuring the health and safety of community health workers through education, provision of personal protective equipment, and also provision of psychosocial support is indeed a critical success factor for successful response of any health threats like the COVID pandemic among the community. It's also good to look at the service delivery modalities and decide which one to maintain and which one to be modified with a new innovative approach when we are in such pandemics. Last but not least, when we talk and think of primary healthcare approach as an effective and cost-efficient means of achieving GHPC, we should at the same time underscore the key and indispensable role of community health workers in terms of achieving those global declarations and commitments, including the Astana Declaration and the Sustainable Development Goals. Once again, thank you so much for giving me this opportunity. Back to you, Neil.
Thank you so much, Dr. Shitilu, for elaborating programming for the last mile health, programming that prioritizes the last mile health. And now on to our third speaker for the fourth P, which is very important, political priority. Over to you, Sarah Maleba from Living Goods as the Director of Global Health Systems.
Good morning, good afternoon, good evening, everybody. I'll just take the next few minutes to give a few remarks around how government has been supporting community health programs to continue service delivery during COVID. And indeed, we have seen a lot of political prioritization and commitment in three major ways. One of the big ways is around coordination. The other one is around policy direction. And the third one, which is essential to what we are discussing, is repurposing or financing of funds. So I'll speak a little bit around coordination. We have seen and indeed continue to encourage governments to do a lot of coordination within and across governments. We had the WHO really encouraging governments to take a whole of government approach in terms of prioritizing the pandemic. And we have seen in many of the countries that besides just taking the whole of government approach in terms of prioritizing the pandemic, governments quickly also began to prioritize essential health service delivery, especially after support and influence from various partners and players who called on government to ensure that we do not roll back the gains in reproductive, maternal, and newborn health. And so with coordination, we've seen governments bring a lot of partners and implementers and other sectors at the table to ensure an integrated and holistic approach that ensures maintenance of essential services as well as a robust COVID response. And as this coordination continues, we need to ensure that it is strengthened as we go through the various phases of the pandemic. We're still working through the emergency phase. As we begin to recover and rebuild, the coordination within government is extremely essential, and especially when we think about health with regard to the health facility level as well as the community health level, ensuring that we truly have an integrated approach. Speaking about policy direction, we have seen government really developing and revising policies and strategies and guidelines with the support of other players, including partners on this call, to ensure that we include, we enhance, and also outline the community health worker roles and responsibilities within the service continuity and the COVID response. And we have seen a lot of policy direction at country level, drawing a lot from the global and regional guidance. And we want to pray and hope that governments will continue to do this, and especially ensure that it is clear the role of community health workers in ensuring service continuity and the COVID response, really putting the mechanisms, the policies, the guidelines and direction at the disposal of community health workers as we all continue to respond. The third and the most important one is that indeed all this takes financing and resourcing in various ways, both the money side of things as well as the human resource. And we have seen and continue to encourage governments to work around repurposing of funds at government level, at partner and donor level, to ensure that we respond to COVID in a way that prioritizes the key requirements. We have heard from the community health worker in Uganda about the need for PPE. We need to really think about core activities that will really drive the impact of the response at the community level and really ensure that we continue to save lives, even though we are within an emergency situation. So I will wrap up and say that if governments continue to prioritize the COVID response as well as essential service delivery, the role of community health can only come in place when government factors the work and the role of community health within the coordination mechanisms, within the policy direction, as well as within the financing reorganization. Thank you very much. Back to you, Nelly.
Oh, I was speaking on mute. Thank you very much, Sarah Malaba, for taking us through the third P. Finally, to the fourth P. Remember, we are talking about the 4 Ps for investing in community health is around financing. And it's a good segue from Sarah, who has alluded to that, because if we are to equip our community health workers with PPEs, if we are to program, while prioritizing the last mile, if we are to provide services, essential health services, we need financing. And it is always the big elephant in the room. And the case for investment in community health is very, very clear. Research and evidence has demonstrated that investing in community health worker programs in sub-Saharan Africa can yield up to a return of 10 to 1. For every dollar you invest, there is a $10 back in return. How? Through enhanced productivity. Remember, it's the communities, it's the people who are working, and so there's enhanced productivity. There is protection from pandemic and other health crises, and we have seen community health workers, our community health worker in Uganda, preventing and averting, the pandemic, which has great ramifications for our economies. And then thirdly, in terms of employment, because when you pay community health workers, there is an economic multiplier effect that translates to positive outcomes in the community. If you pay that community health worker, they're able to take their child to school, they're able to buy, things from the shop, they're able to support their families. And so that is what we look at when we say there's a return on investment in community health. So then with this sound evidence, why do we still have the gap in funding? Why are we still having verticalized funding? So one of the things that we need to recognize is funding flows easily where there is a plan. And so the first step that we need to support our governments, who are the leaders when it comes to provision of public health care, is help them establish and set up community health plans. This is in form of strategies, operational plans. Then help them cost these plans. And actually, while doing the strategy, we are thinking about the design. How do we design community health worker programs that are designed to deliver? Not over-bloated programs or programs that are too expensive or programs that are unsustainable, but programs that are very targeted and integrated to deliver. And then costing of those programs. You cannot fund something that you don't know how much it would cost to fund. After that, we can support governments to develop investment cases, because you and I in healthcare easily understand this language. When we talk about community health workers need PPEs so that they can go and give that mother an ITN, we do understand. But our colleagues in finance need to be convinced that this is not a black hole. There's actually a return on investment. So building and creating that investment case is very critical, and it is used to rally champions towards community health, and it is used to actually help the government to politically prioritize and make decisions to repurpose and finance the community health worker programs. The last but not the least is there are many innovative ways of financing which we can tap into in the countries. First off is, of course, we need the government to take the lead with domestic resources. There are donor funds. There are also other innovative ways of financing community health worker programs, e.g. through blended financing, tapping into private sector, a team that we shouldn't forget or ignore. And we are saying that community health programs is an open table where we welcome the private sector to join hands so that we can invest in community health worker programs. And lastly, we keep talking about the gap, but we should also think the resources that we currently have, are we using them more efficiently and more effectively? And this goes to addressing the verticalization of funding and the fragmentation of funding. So this would be a call to action that let us refocus funding into a more integrated way rather than a fragmented way, so that we can even take advantage of economies of scale. We can reduce on our overheads, and we can actually create more impact by having more health for money. And with that, ladies and gentlemen, we conclude our session by reminding you the 4 P's that you should not forget as you leave this session that are key to ensuring that we invest in our community health programs and we do not forget our children who are our future. 1, protect our community health workers. 2, programming that prioritizes the last mile health, the last mile. 3, political prioritization. And 4, proper funding. Thank you very much, ladies and gentlemen. We welcome questions. Charisma, are there some questions?
I don't see any questions at this time, but what we can do is always just have a very large question discussion at the end of the next group presentation. So we could just go ahead and move on to the second speaker, if that's okay with everyone else. And at this time, I would like to introduce and pass on to the second portion of the session to Cicely Thomas, who will be introducing our second set of speakers.
Thanks very much, Charisma. And thank you so much to Nellie and colleagues for that really interesting presentation. I think some of the work that we'll present actually leads on quite a bit from the engagement that you mentioned and importance of involving government and a variety of stakeholders in bringing together funds for community health work. So good day to all of you joining us from around the world. My name is Cicely Thomas, and I lead a portfolio of work focused on public-private engagement in mixed health systems that results for development in Washington, D.C. Today, we'd like to share with you some of the work that we've been leading with support from the Merck for Mothers initiative to consider how we strengthen partnerships and engagements between the public and private sectors to improve maternal, child, and adolescent health. But first, I want to start by introducing my colleagues who will be speaking with me today. Dr. Lyndon Marani is a medical doctor and senior health systems consultant with Insight Health Advisors based in Nairobi, Kenya. Jadev Anand is a technical specialist with Access Health International based in Mumbai, India. And Courtney Tolmie is a senior fellow with Results for Development based here in the US. Next slide. So I want to start with some background. Increasingly, as countries are working towards achieving universal health coverage and improving maternal, child, and adolescent health, they've begun to recognize that they really must engage the private sector. But the challenges come when the public and private sectors attempt to do so. And they're faced with this question of how do we go about doing this? So next slide, recognizing this, we aimed to research and demonstrate and produce some global knowledge on the practical ways that countries can improve engagement between public and private sectors and integrate quality private maternal and adolescent and child health care in government stewarded health systems. And one of the questions we really wanted to answer was, what factors influence the success or lack thereof of public-private engagements? So based on an evidence review and our own tacit knowledge through country experience, we developed a PPE ecosystem. And PPE here, I'm referring to public-private engagement. So next slide. The ecosystem recognizes that public-private engagement exists as part of a complex network of helping and hindering factors, and multiple health system actors as well, operating at various points of an engagement cycle. And so the ecosystem that we've proposed consists of 3 factor sets, one being the environmental factors that shape the operating environment for a given public-private engagement. And these factors are factors that individual actors themselves in an engagement likely have indirect, if any, influence on, but they still impact the engagement's effectiveness, and so they should be considered. And these are things like the political economy, the economics of the system, legal and health system organization factors. We also have structural factors that define the architecture of a given public-private engagement, and that includes the type of partnership model. So this might be a bilateral engagement between 2 parties, or maybe there's a neutral broker that brokers that relationship. It also talks about the formalities of the model. So is there a formal memorandum of understanding for existence between the parties, and the available resources to run this engagement together. And then we have the engagement factors, which you see in the middle of this diagram here, that relate to the actors who are implicated in this engagement. And generally, these actors have more control over these factors than they do over, say, the environmental factors. And these include what we're calling foundational and operational factors. So they include trust, mutual understanding, willingness to engage, and operational factors like managerial and technical capacities, communication, etc. And these engagement factors are sometimes considered or sometimes thought of as these soft factors, but they often go overlooked when we're thinking about how to engage between parties. So in addition to this factor set, we also have a validated health system gap. And the gap refers to the health system problem or challenge that's identified by stakeholders that the engagement is seeking to solve. And we believe that that gap should really be based on evidence, aligned with beneficiary demand, and validated by a critical mass of stakeholders within the system. We think that public-private engagements that ensure that they're responding to a validated health system gap will be more likely to succeed. And so in summary, we hypothesize that if engagement actors consider the environmental, the structural, and the engagement factors, and they design their engagement around a solution to fill a validated gap in the system, then the engagement will be more likely to achieve its outcomes and be sustainable. So to put it simply, we believe that a more holistic approach to public-private engagement in health is needed, and that it's really this interplay between these factors that will influence the success of the engagement. So now that we put this framing in place, what does it mean for how we actually approached work in countries, the exciting part that my colleagues will share with us? So we recognize that the engagement factors go overlooked, as I mentioned, and we made sure to consider this as we designed our approach in supporting country partners. So our team acted as a neutral broker supporting public-private engagements, and we embarked on a series of support activities which broadly included sector-specific discussions, first with one sector, the public sector, and then with another sector, the private sector, to collect emerging information about the factors, the health system gap that they were targeting, and their priorities. And then we facilitated a joint discussion or co-creation sessions with the public and private actors together to support dialogue and joint problem analysis across the sectors, as well as build trust. And then our support we supported a variety of actions to address the different challenges that they identified in these factor sets, whether they be environmental or structural, some sort of lack of platform to engage on, or even the dynamics between the actors. Maybe there were issues of trust or misalignment between understanding of what the work was to achieve. So since late 2019, R4D and its partners in Kenya, Insight Health Advisors, and in India, Access Health International, have worked with public-private health representatives to work on two issues in parallel. So one was addressing the health system challenges, which in these examples that we'll share with you are related to access and quality of maternal, child, and adolescent health, but really could apply to a variety of health system challenges. And the second was strengthening this engagement and the structural elements between the public and private sectors by leveraging factors that bolster relations and mitigating those that hinder them. So my colleagues in our panel before talked a lot about this, but one, of course, big system shock during this time was COVID-19. And we'll mention a little of how we managed to work around and indeed leverage this challenge throughout the work. So my colleagues will now share a short overview of this work in these two countries and how we've taken this holistic approach to PPE. Over to you, Dr. Marani.
Thank you for the Dr. Cecily. As Cecily has mentioned, what we were trying to do was to try and figure out the how of utilizing the private engagements to improve maternal child health outcomes. And our program was working in Kakamega County, which is one of the counties in Western Kenya. And our hope was to utilize the infrastructure that has already been set up by the private sector to decongest the public sector, which typically handles quite large volumes. As Cecily had pointed out, the process that we intended to use was first of all to go through a co-creation process where we could identify the challenges that both the public and the private sector actually face. And once we had unpacked the engagement factors to try and actually build mechanisms that would maintain this engagement, and also to develop an action plan that both the private sector and the public sector could actually utilize to meet this particular agenda of improving maternal health outcomes. One of the most interesting things that we came across immediately is that both the public and the private sector imagined that they were actually doing all that they could to engage with each other. So the public sector folk were imagining that so long as they carried out their regulatory function, they were actually participating in PPE. And the private sector, on the other hand, believed so long as we are complying with what the government is saying, we are actually doing everything that we're supposed to do as far as PPE is concerned. And unfortunately, this belief that everybody was doing what they was supposed to be doing ended up resulting in some animosity. There was some friction where, to some extent, the private sector felt that the government was too forceful or rigid in the way they went about their regulatory function. They felt harassed to some extent. And the private sector, the public sector, on the other hand, felt that the private sector was not doing enough to actually carry the load in as far as maternal child health services were concerned. So some of the factors that we unpacked during that phase was that there was no specific forum that was available to enable engagement and conversation between the public and the private sector. So while on paper there was supposed to be a stakeholder forum, this stakeholder forum was actually meeting quite ad hoc, and it was not one that was set in a manner to allow for the private sector to actually air their issues. It was more like for the public sector to give policy direction and the like. Hence, it did not help in resolving the adversarial relationship that was there between the public and the private sector. Then COVID struck. Then something very interesting happened. immediately the public sector actually realized that they did not have the infrastructure that they needed to handle the COVID pandemic if we ended up seeing the kind of numbers that were being reported from Europe and the Americas. So they had to figure out how do we engage the private sector in a more meaningful manner. So ideas started coming on the table. For example, if the main public hospital was inundated by COVID patients, could we use a private sector facility to be the maternal child health facility for the entire county? So at that point, we realized that we had a couple of enabling factors which were working in our favor. One was the realization that the private sector was actually handling up to 50% of the healthcare services within the county. And at that time, there was a deep desire by both the public and the private sector to build on whatever synergies they had. The healthcare services in Kenya have also been devolved, meaning that the counties have autonomy in how decisions in healthcare are made. And to quite a large extent, the health leadership within Kakamega County was able to become was quite agile at developing new strategies which brought on board the private sector to work with them, including entrenching the stakeholder forums, so that the stakeholder forum became a communication modality to pass information on COVID and receive information from the private sector as well as other players. Formation of subcommittees of this stakeholder forum to handle M&A issues, communication issues, service delivery issues, as well as setting up a feedback loop in terms of information as far as COVID was concerned. Now, to the tail end of 2020, we actually leveraged these systems that had been put in place during COVID to actually bring to refocus the program back towards maternal child health issues, and the stakeholder forum, which has now been entrenched within Kakamega County, then was utilized to form subcommittees that included a PPE subcommittee as well as a development partners subcommittee. This was also enabled by having a dynamic and young leadership within the county health leadership, which truly helped facilitate us moving forward.
Thank you very much.
Yeah.
Great. We'll move to you, Jadev, if you could share with us some of the lessons from India.
Thank you, Cicely, and hello, everyone. So before we really get into the details of things, perhaps some background and context of the Lakshya Manata program or initiative in India. So Lakshya Manata was really born out of independent efforts being made by the public and private sector to improve quality of maternal and neonatal care in India. The government of India over the last 3 to 4 years has been running the Lakshya program to improve maternal and neonatal quality of care, while the Federation of Obstetric and Gynecological Society of India, a pan-India association of specialists, has launched the Manata program, which looks to improve quality of services in the private sector. At the end of 2019, the government of Maharashtra, which is a state, or as you would say, a province in India, understood that there are great interdependencies between the public and private sector in achieving these health goals, and partnered Foxy to standardize quality of care across the state. Now, of course, given that this program was rolled out towards the end of 2019, there has been a fair amount of slowdown in momentum because of the pandemic, but nevertheless, proactive steps were taken, to take a lot of the assessments online, etc., and really try to keep this program going. So as a team, what we were looking to do is really understand that, within the context of having been planned and rolled out and formalized, how is the engagement currently playing out between the public and private sector? As a first step, we carried out a systems integration assessment, which looked at the environmental factors, you may recall from the framework. Of course, a lot of these are, binding constraints at times where, they are not in the direct control of either the public or private stakeholders. Just to give you an example, specifically in the context of Lakshya Manata. This was a fairly localized program with the government of Maharashtra, but it's open to question how that would really translate in another political setting in a different state. So moving forward, we also try to understand what are the structural factors and engagement factors impacting this initiative. To understand the structural factors, we carried out qualitative sort of discussions with a lot of the stakeholders from the public and private sector. And the emerging finding really was that while the broader goal of the program was agreed upon between the public and private sector, there seemed to be a disconnect in terms of what the actual vision of the program is. So for example, on the public side, I think they were still, trying to articulate their vision as to what the program may, develop into. And within the private sector at Foxy, there were differing and diverging voices as to whether the program should be institutionalized or, should it just run parallel, independent of any sort of formal governance oversight from the state government. In terms of the engagement factors, we also had a self-assessment of the dimensions mentioned within the engagement factors and various sub-dimensions therein. The real takeaway, which surprisingly was very similar to the experience in Kenya, is that the government tends to have, the public sector tends to have a fairly, positive perspective, a positive spin of how the developments are really going on and how the engagement is playing out. While what we noticed among the private sector stakeholders, there was definitely a lot more, it was felt that there was a lot more need for improvement. I mean, some of these dimensions included, of course, communication, accountability, and just as an example, with accountability, the government felt that there is an MOU, a Memorandum of Understanding, or a Goodwill Agreement on which the Lakshya Manata initiative is based. And a lot of the relational factors and the accountability measures are defined therein. But when we spoke to the private sector stakeholders, they felt that, yes, while it is really there on paper, in action, it's very different. And really detailing out the roles and responsibilities and accountabilities is something that hasn't happened yet, and is probably something that would need further discussion and discourse. So to sum it up, owing to a lot of things happening online and the busy, scheduling, we are yet to sort of conduct that final virtual workshop where we're hoping to get the public and private sector stakeholders together in a room and really iron out some of, what would be the immediate next steps to strengthen the engagement factors, as well as help partners align on a broader vision to, really ascertain what is needed to impact the scale and positively impact the scale and sustainability of the Lakshya Manata program. That's all from me.
Great. Thank you, Jaidev and Dr. Marani and Cicely. I'm cognizant of time and I want to make sure we have a few minutes for discussion and questions. So I'm going to wrap up very quickly. One of the most exciting and I think interesting parts of this project for us is that from the beginning, we've created this very embedded and adaptive learning agenda so that while all of this work is happening in Kenya and India and beyond, we're really starting to try to answer these questions and gather more evidence about what are the factors that are most important for making PPE successful or for potentially hindering the effectiveness of public-private engagements. And then, the reason why that matters is that understanding things like what Jaidev and Marani spoke about earlier, these factors that make a difference, whether they be engagement or structural or environmental, we can start to provide guidance and an understanding of how these types of factors can be either leveraged if they're helping public-private engagements or potentially mitigated if they're generally seen as harmful. So there's a lot we can unpack here, and actually just a plug for the project. Over the next 3 to 6 months, we're going to have all of our learning reports and research coming out. This includes our systematic review of the evidence that Cicely mentioned earlier, primary case analysis of the work that Marani and Jaidev spoke about in Kenya and India, as well as the secondary case analysis, because we wanted to really broaden the scope of what we were looking at and say, if we look at a wider range of different engagements, are these same sorts of factors coming up over and over again? And we're starting to see this. We see things like mutual understanding between the sectors and technical and managerial capacity, as well as the role of external shocks such as COVID. by understanding more how these factors played a role in engagements, and then starting to unpack how we can try to make them either better, to make engagements more effective, or to try to really mitigate them to make the problems that may come up related to these factors less of an influence. We think that this is going to provide really, really important insight for the field, for those of us who are working to support mixed health systems. So with that, I know we have a few more minutes, so maybe I'll open it up and see if there's questions either in the chat, or please feel welcome to unmute yourself if you do have a question, either for this session, or I know we moved really quickly from the previous session as well. So happy to open things up and talk more about the learnings from, I think, these two exciting discussions. Great. So I see one question in the chat here from Aaron. So where would I find more on the PPE model and implementing it? Cicely, do you want to talk a little bit about kind of what's coming out from this work moving forward, and where Aaron and others can find more?
Sure. Thanks so much, Erin, for that question. And maybe, Courtney, you could put the link to our blog on the ecosystem in the chat. We'll be publishing a lot of this work in the coming month and a half. So we'd be happy to share more, but I think the exciting pieces around the country work are what everyone is kind of eager to hear about. So we've published a couple of blogs with this information, and we have an upcoming piece in a journal as well. But we will also be conducting a webinar in the next month, and hope to get the learnings out through a couple of other websites and dissemination platforms. So we'd be happy to share with you. We can note down your name as well, but please let us know if you have ideas of how to share this, especially in countries that you're working in. I think that is the toughest area to get this information across in. In both the India and Kenya examples, we do hope to be disseminating that through government and private sector actors there as well.
Great. Thanks, Cicely. And since I'm sharing my screen, I actually can't get the link, but asked Emily if she could put it in. So we also have a comment from Sarah, who presented in the last session, saying, I think most of what you've shared is translatable in unblocking health systems challenges. Sarah, do you want to maybe say, you could unmute yourself and say a word about that? Because I do think there are some really interesting linkages between the work that we've talked about and the work that you all shared earlier.
Yeah, I think in just thinking about what was mentioned last around an embedded adaptive learning agenda, and also thinking about the systematic review of all the environmental and structural issues, really speak to some of the key issues around when you are trying to unblock bottlenecks, or really understand the dynamics of what is going on within a health system. Because we all know and appreciate the health system's building blocks, but the big question is why doesn't it just work? So there are various constraints, and I think that what you have shared really also speaks not only to the public-private engagement issues, but also I could look at it from a health systems perspective and approaches that we could use as we try to understand how we could strengthen health systems.
Great, thanks, Sarah. I think we have time. I think I saw that Charisma said we could stay on for another couple of minutes, and I know people may have to leave, they may have hard stops, but I think we have time for another question or two if useful.
I have a question for our colleagues who presented in the first panel. I was really interested to hear about some of the financing opportunities you mentioned, but I also know from our work over the years how difficult it is to have some of those discussions. I'm curious if you think some of the factors that we talked about, and particularly some of these kind of soft factors, are things that you've been thinking about too as you help to have those discussions between government, community leaders, private sector, etc. Maybe to you, Nellie.
Yeah, sure. Thanks, Cicely. As you're doing this, I was just reminiscing of what it really takes to actually do resource mobilization. Often we find ourselves in a very tricky place because governments have limited fiscal spaces, competing health priorities. You know, you wake up to COVID, you've not even tackled malaria, mothers are dying. So very, very many competing health priorities. So then what are the other sources of funding that we could tap into? And so the private sector has come up over and over again in our discussions, but it's always then how do we engage private sector? Right? How do we create that business case for them to actually invest in community health? And it's a question that still lingers, and would be happy to actually read the framework that you have and the ideas that you have, and probably have a further conversation on how you can help us shape that. We did have a country like Malawi that approached us to help them figure out how they could tap into using PPPs as a way to finance their community health worker program, because in their program they have health posts, you know, they are infrastructural, they are quite, you know, taking a significant chunk of their cost of their program. And so they were thinking of tapping into private sector. And you can guess what happened? Not very positive. What happened is they were able to map up who their potential private sector would be, but all those issues that you have outlined, those soft issues, those issues of not being able to translate what we really need that would be more appealing to private sector, that fizzled out. And I believe with your help, perhaps it's a discussion that can be revived. Thank you.
Great. Well, this has been fantastic. I think an admittedly short discussion at the end, and it seems like there's a lot more to follow up on. You know, we will definitely be in touch with the team that presented first, with Nellie and others. But, you know, just a final word, please do reach out to, I think, any of the presenters if you're interested in learning more or engaging more. And thank you to the core group for providing us with the opportunity to share and to start to unpack some of these learnings.
Yes, and I just wanted to thank all of our presenters and participants for such a great conversation on everything that we learned today. And just as we conclude this session, I would just like to again thank everyone for coming out and bearing with us, especially with the lengthened time and everything. And if you would like, please feel free to head back to the conference website to view the posters in the exhibition hall, as well as join the marketplace sessions later.
Great, thank you all.
Thank you, guys.
Thanks, everyone.
Thanks, everyone. Bye.
Thanks, everybody. Bye.
Bye-bye.
Bye, thank you.